Howdy everybody, welcome back to MSK. My name is Jonathan, and today we are going to be talking about fractures of the humerus. Let's get into it. We'll start with the etiology, and so a very common cause of humerus fractures will be indirect trauma to the arm, with the most common cause being falling on an outstretched hand. This kind of fracture is more common in older populations, and part of that is because older people often have less dense bones, and so something like falling onto your hands can be enough trauma to travel up the arm and fracture the humerus. Additionally, there could be a direct trauma to the arm. This might be something we see in more high energy incidents like a motor vehicle accident or maybe even getting hit in a sports injury. This could also be a case of a pathological fracture. This is any incident where there's not adequate trauma to normally cause a fracture, but an underlying bone disease such as osteitis deformans, in a case where a patient's bones become larger and more fragile, predispose the patient to a fracture. We'll move on now and talk about the presentation of humerus fractures. So the big thing that patients are going to come in with if they have fractured their humerus is pain. Their arm is going to hurt. There may also be swelling and limited mobility of the affected arm. We may also have a shortening of the arm, as would likely be in the case in this patient here. So luckily, they put a nice little red arrow for us to see that something is going wrong in this arm. Because the muscles of the arm are likely still intact, that will provide an upward force on the distal portion of the broken arm. A very important complication for you to know about is that a patient may have radial nerve palsy, especially with a mid-shaft fracture, or really anywhere along here inside the bone. So what sort of things are going to make us suspect that there's radial nerve palsy in a patient with a humerus fracture? Well, for one, they'll have numbness along the dorsum of the forearm and radial hand, because this is the area innervated by the radial nerve. Additionally, they may present with a wrist drop. Recall that the radial nerve innervates the extensors of the wrist, and so if we lose function of those extensors, then the patient's hand may be drooping in front with them unable to extend it, looking something like this. The patient will also likely have a decreased grip strength. There will be weakness in all of the muscles innervated by the radial nerve, and because we need our wrist extensors for maximum grip strength, patients with radial nerve palsy will likely have decreased grip strength on the affected side. Recall that the radial nerve also innervates the tricep, but tricep function may be spared even in a mid-shaft fracture with a radial nerve injury because the branches for the tricep have likely already come off the radial nerve. You can check out the radial nerve video where we go into more details about that. And even though the radial nerve is the most likely to be injured, especially with a mid-shaft fracture, it's possible to injure other nerves as well. So we may have the axillary nerve damage, which is more common if there's injury up here near the surgical neck of the humerus, or we may have the median nerve damaged, which is more common if we have a supracondylar fracture in the distal part of the humerus. And this very conveniently spells arm for us as we go down the arm. And the last complication we'll talk about will be an injury to the brachial artery, which will run here along the arm. So if we fracture our humerus, this can compress or damage the artery and potentially lead to ischemia of the downstream tissues. So we'll always want to check the radial artery to see if there's still a pulse in the arm. Alright, and moving on to diagnostics, we'll obviously want to get an x-ray in order to visualize the fracture and see any potential displacement, dislocation, or angulation of the bone. In this x-ray down here, it's very easy to see the displaced fracture, but not all fractures will be this severe, and sometimes only a minor angle change or an angulation will be seen in a patient. Additionally, because the humerus fracture is often a trauma-induced injury, we'll want to visualize nearby structures to make sure that there's not any other problems with dislocation or displacement going on. And finally, we'll talk about management. So because pain is going to be a big symptom of these patients, pain management will obviously be a part of our process. So acetaminophen, NSAIDs, and opioids depending on the severity and the type of patient that we have. Longer-term treatment of the arm will include immobilization of the arm with a sling or cooptation splint in order for the bone to heal. And once a patient has healed enough, they'll begin physical therapy to mitigate some of the muscular changes that will happen when a patient doesn't use their arm for weeks at a time. And of course, we'll need to consider surgical intervention, especially if there have been complications like radial nerve palsy or brachial artery injury. Alright, let's do a recap and then we'll do a practice question together. Humerus fractures are most common caused by trauma, either direct or indirect, with the most common cause being falling on an outstretched hand, and this is typically seen in older populations. Additionally, pathological fractures can contribute to the breaking of this bone. Your patient will have pain, swelling, and limited mobility of the arm and may have a shortening of the arm, especially depending on the displacement of the bone. If there's been radial nerve damage, which is more common in a mid-shaft fracture, The patient will have weakness, numbness, wrist drop, and decreased grip strength. Additionally, an axillary or median nerve damage is also possible on the proximal and distal parts of a humerus. We'll use an X-ray to visualize the fracture, and for the patient, we'll give them painkillers, immobilization for the long term, and then once they've healed, they can have physical therapy, and we must always consider surgical intervention. And a practice question might sound something like this. A 73-year-old female presents to your emergency department with right-sided arm pain after a fall. The patient reports tripping on an uneven sidewalk and trying to catch her fall with her hands. Her vital signs are within normal limits. On physical exam, you notice that there is redness and swelling on the affected side, as well as wrist drop and 2 out of 5 grip strength. Which area of skin on this patient's affected side is most likely to have a reduced sensation? So this patient is an older woman that comes in after falling on an outstretched hand. She has pain and swelling on her affected side, as well as wrist drop and decreased grip strength. So we suspect that there is radial nerve palsy in addition to her humerus fracture. So for the question as to what area of skin will be most likely affected, that will be the posterior forearm and radial hand, as that's innervated by the radial nerve. Alright, that's everything from me today. Thanks for watching, good luck studying, and I'll see you next time.